So we have approval of ivosidenib for IDH1 mutant relapse refractory patients. Now, this has predominantly been used in patients that are either HMA failure, chemo exposed, clearly high risk. But the question is, if we intervene early, can this potentially change the natural history of the disease? And we published a little while back that particularly in lower risk myelodysplastic syndromes, that patients with IDH mutations present with severe neutropenia, and there's really very little, if any, therapy that can ameliorate that. So I'd say now, actually maybe dating back around 7 years, we've started to incorporate frontline IDH inhibitors. I'd say more ivosidenib, but some enasidenib as well. And actually, we've had essentially a 100% response rate. My farthest patient is over 6 years with perfectly normal counts. We've typically seen rapid resolution of the neutropenia, but most of these patients have had mild other cytopenias, and those have also, normalized. And this seems to be way better than what we would expect in relapse refractory MDS or AML. And so perhaps if we intervene earliest, that's the time point that we can really prevent the disease from ever changing. Now, these are small numbers, ultra rare patients. I think if people remember, it took over 5 years of time and only 17 patients to get the IDH1 label in relapse refractory MDS. Now, I think going along with this, Kelly Bolton at WashU has been leading a CCUS trial. So IDH1 mutation with CCUS, we're a part of this. So I'd be looking to data at ASH, because I think this will even greater help solidify if we intervene early, our response rate's better and ideally more durable. But toxicity is essentially zero in this upfront setting, and very excited by the results to date.